Good afternoon and good evening, everyone. So thank you so much to attend our ACN YNS webinars today. So today we have our chair today will be Professor Andreas, who is the immediate past president of EANS, European Association of Neurological Societies, the consultant neurosurgeons and spine surgeon of Edinburgh in UK. So we will have three speakers today. And the first one is Professor Roy Daniel, who will be talking about the interventorial approaches during petrosectomy. Professor Roy Daniel is a professor and vice chairman neurosurgery, Lucerne University Hospital in Lucerne, Switzerland. He is also the chair of skull-base surgery section in the EANS. Our second speaker is Dr. Spisus, who will be talking about the 𝑠𝒑𝒏𝒔 target bypass through mini craniotomy in chronic steno-occlusive disease, the case report. So he is a current present fellow in Fujita Benta Hospital. He's also a consultant neurosurgeon in High Care General Hospital in Dhaka in Bangladesh. Our first speaker is Professor George C. William, who will be talking about the corpus callosum, a surgical perspective. He is the director of pediatric professors neurosurgery at Sri Children's Juvenile Institute for Medical Sciences and Technology in India. So our discussion today, we have Professor Otani. Otani Sensei is a clinical professor at the Division of Neurosurgical Surgery and the Department of Surgery in Nippon University School of Medicine. He is also the vice president and chief manager, and also the center of the Brain Center and Skull-Base Lesions of Nippon University Hospital in Japan. Our second discussion is Professor Constantine. Professor Constantine is a professor of neurosurgery of the Department of Neurosurgery, the Jikei University School of Medicine in Tokyo in Japan. So without further delay, shall I invite our chair, Professor Andreas, to introduce our first speakers. Professor Andreas, please.
Thank you, Ben, and a warm welcome to everybody. It's a great pleasure to be with you today. We have a very interesting program and a good variety of expert speakers. So without further ado, I have the privilege and the pleasure to introduce my colleague from the EANS, Roy Daniel, who works in Lausanne in Switzerland, but also chairs the skull-base section of the EANS, to give his first presentation on skull-base approaches around the tent and around the pitcher's bone. So, Roy.
Okay, thank you, Andreas. Can I share my screen?
Yes, please.
Is it okay?
Okay.
Is it full screen? Can you see full screen?
Yes, yes.
Okay. Yep. Thank you, Andreas. Thank you, Professor Kato. And a big thanks to YNS and ACNS and Professor Raja for organizing this meeting. So my topic today is the intertentorial approaches, which is something new in petrosectomy. I was asked to also prepare a slide to introduce myself. So I did my training in the Christian Medical College at Vellore in South India. I did my fellowship in the Royal Adelaide Hospital in Australia. After that, I was faculty in India for 12 years. And then I moved to Switzerland, where I currently work. I also have an appointment in Tumen, Russia. Now, my work essentially involves skull-base surgery, and this is the lab that we have now in Lausanne that is doing some exciting work in cadaver dissections. I also work in the neurobiology lab in Lausanne on the stress and epilepsy models. The two organizations that I work a lot with on a daily basis, one is the IANA, the International Academy of Neurosurgical Anatomy, and we were the previous WFNS Neuroanatomy Committee that has now morphed into the IANA. And the other organization, as Andreas already said, I chair the skull-base section, the European Association of Neurological Societies. So I think this would do as an introduction. And I'll go on to my talk and to describe the anatomy of the petrous bone. So that is the key for petrosal approaches. This is anterior here, this is posterior. So it has a base, which is the mastoid with the antrum and the air cells. The middle aspect has a lot of interesting structures, the internal artery meatus, the nerves, the middle ear, and the semicircular canal. Then you have the apex, where you have the petrous segment of the ICA, the Meckel's cave, and the cochlea. So the approaches to the petrous bone. So the classical two approaches are the anterior petrosal, which is the subtemporal epidural approach. Then you have the posterior petrosectomy, which is through the posterior part of the bone, through the base after a mastoidectomy. And if you were to do both of this, then that's what you would call a combined petrosal. This is just to make sure that we are clear with the nomenclature of petrosal approaches. Now, what is the anterior petrosal approach? It is an extradural subtemporal route to the petrous apex and the posterior fossa through the middle fossa. So its indications are to treat anything in this region, the upper petroclival region, medial to the fifth nerve, and ventral to the IAC. So it gives a beautiful ventrolateral exposure to the brainstem, and it treats a host of pathologies in this region. So the anterior petrosal approach, the approach is through the middle fossa. So the area between the sphenoid ridge and the anterior border of the petrous ridge. So this is the target here, and that's your orientation. So it's extradural, and it involves removal of the petrous apex. So that's the part of bone that we need to remove during this approach to access anything in this region. So the ventrolateral brainstem. So if you look at the petrous bone from medially, you see the important structures. So you see the ridge here where you will find the superior petrosal sinus, and then you have it's bordered next to the clivus with the inferior petrosal sinus, and both these sinuses join here in the confluence. And then you see the internal auditory meatus, and below you have the petrosal part of the and the sigmoid parts of the jugular foramen. And that's the bone that we want to remove to give access to this region. Now, there are some key anatomical landmarks. I made this talk very basic because this is for the young neurosurgeons. So it may be a little bit too much of a repetition for the senior parts of the audience, but this is a very basic presentation. So if you draw the projection of the root of the zygoma, and this is where the root of the zygoma attaches, the anterior part of it corresponds in the depth to the ovale, foramen ovale, and the mid part corresponds to the spinosum, and the posterior part to the geniculate ganglia. Now, this is important because when you're going extradural, you need to know in which direction you need to go. So orthogonally to these 3 points, these are the 3 internal organs that we can access. So this is a cadaver dissection that you see there. You can see the dura has been reflected. That's the GSPN, and that's the trigeminal nerve. So those are the 3 roots of the trigeminal, and this is anterior here. So this is V3, V2, and V1. And if you were to cut these and to move them, you would expose the carotid, the petrous part of the carotid. So these are structures that border this particular zone. So it's very next to the carotid in the Glasgow triangle. And there you see some pictures from the Roten atlas, and you see the middle meningeal artery here, the 7th nerve within the bone after the drilling. But in the patient, this is the view that you will get, because you will be seeing it with the superior petrosal sinus towards you. And that's the external auditory canal. That's the root, the 3rd root of the trigeminal, and that's the petrous apex that needs to be removed. So the posterior border, of course, is the semicircular canals here, which is the arcuate eminence when you start off. And that's a cartoon that shows the borders of the Cavaz's triangle. The standard dural opening, once you do a petrosectomy, are these. You have a posterior fossa dura opening, then you have a temporal opening, and then you ligate and cut across the superior petrosal sinus, and then you have an access to the region of interest. So this is again to show the dural openings, a cartoon that shows you where it is, and there you have the tentorium, which can also be cut. And once you do all that, you can see the posterior fossa contents. You can see the trigeminal root and zone. You can see the superior cerebellar artery and all the other structures in this region. Now, you can make this much larger if you do the combined petrocell approach. So you do an anterior petrosectomy and a posterior petrosectomy, and then you can dramatically improve your exposure. So these are the advantages of the petrocell approach. If you have a meningioma there, you can devascularize it very well. It reduces the working distance to such a deep pathology. It gives you multiple lines of sight to the tumor and the cranial nerves, and you have very good control of the interface with the brainstem. What are its problems? It is time consuming. It's technically demanding. It needs a good dural repair to avoid a leak. And because you're close to many hearing structures, like the cochlea, for instance, or the semicircular canals, you have a risk for hearing impairment. And then, of course, you have the problems that can be related to the exposure of the temporal lobe and the veins of the temporal lobe. So a lot of people have gone away from this approach, considering that it is a morbid approach, and it was highlighted by Spetzler's group, in which they showed the difference between combined petrocell in comparison to the classical retrosigmoid approach. But then it was not a fair comparison, because there were very few patients in the combined petrocell, approach, and they also did transcochlear approach in this group. So that's the most advanced form of the combined petrocell approach, and it was, in my view, not a very fair comparison. And then, of course, you have to talk about the newer approaches. So we did a systematic review and meta-analysis of the complications known with petrocell approach, and the complication rates were, these are the rates here: facial, hearing problems, CSF leak, venous issues, and temporal lobe issues. But then you have to differentiate between localization-related complications, that means something in relation to the tumor excision, versus approach-related. So not all these complications are related to the approach. So, and therefore, we felt that the rates were comparable to other approaches, and therefore, it has still got an important place in the armamentarium for a skull-based surgeon. What the main problem with this approach is the fact that the temporal lobe is in the way, and that needs to be mobilized, and that puts the lobe at risk. And this group that studied this showed that there is at least 6% problems with the temporal lobe. And the other major problem is with the vein of Ľabe. So that is at risk with any subtemporal retraction. So these are the considerations when you think of petrosectomy. And this is why from our laboratory, we designed new approaches that can limit these temporal lobe issues. And that's what I'd like to present to you today. And there's these two papers that I urge you to read up in ACTA and operative neurosurgery that will clearly reduce the temporal lobe problems related to this approach. And I'll take you through these approaches. Please look at this coronal cartoons and the cadaver dissection. The key of this approach is the superior petrocell sinus. So if you were to do a petrosectomy, either an anterior petrosectomy or a posterior or a combined, this is what you would be left with, a bone defect here, and you'd keep the semicircular canals intact so as to preserve hearing. But what it allows you to do is to reach extradurally the superior petrocell sinus. And once you reach the superior petrocell sinus, the idea is to make a small intertentorial approach, to make a small incision within the leaves of the tentorium. And that can be split into two, and that's what we'd like to call the temporal tentorial leaf and the posterior fossa tentorial leaf. And this just opens out, very similar to the opening of the lateral wall of cavernous sinus, because actually it is an extension of the lateral wall of cavernous sinus. So this can be easily done. And we have now 3 years of experience with this, and I've never had a failure in getting in between these two layers. So this is the PF-TL that you see here, and that's the opening, and you can separate it between the PF-TL and the TTL. I can show you videos of the cadaver dissection. So this is the retrolabyrinthine 𝒂𝒑𝒏𝒄 combined 𝒂𝒑𝒏𝒄 that's been done. I showed you these pictures already, the splitting of the tentorium into two layers, the TTL and the PFTL. And then this is the video that shows you how to do it. Now you can do it either anteriorly or posteriorly. We find it easier to find it closer to the V3. And once you get that opening between the two layers, then it just opens like a book. And that you see there is the superior petrosal sinus. And then these are the two layers. So there you have the PFTL, and then the one you're retracting is the TTL. So these are the two layers that have been developed. Now, the important thing is that if you open this here, you're on the lateral surface of the brainstem. And just imagine you've not seen the cerebellum, you have not seen the temporal lobe, and you can reach the brainstem without a problem by just opening these two layers. So there, you make a small opening and you see the fourth nerve in the cistern, just lateral to the stem. So this is the crux of the matter. And then you do your dural openings. If you want to go towards the posterior fossa, you open the posterior fossa tentorial layer, and then you open the PFTL, and that gets you to the posterior fossa. If you want to go towards the temporal lobe, then you need to open the TTL. So that's the ligation of the cutting of the superior petrosal sinus. And after that, you have the tentorium. You just keep cutting the tentorium till you reach the hiatus, but make sure you're behind the fourth nerve so that you don't injure it. And that's a vein that's going into that, which is frequently taken in any petrosal approach. And there you complete your dural incisions of the tentorial hiatus behind the fourth nerve. And then you have the lateral surface of the brainstem there, the fourth nerve, the fifth, the root and rhizome. This is essentially the approach that we are talking about. So you can also do it through what you saw before was a combined petrosectomy. You can also do it through an anterior petrosectomy, exactly the same thing, superior petrosal sinus. And then you have your dural incisions that you can decide how you want to do it, depending on the pathology you want to address. And those are the structures that you see lateral to the brainstem. What are the limits of the intertentorial approach? The one thing that you cannot do, because you're not opening the temporal dura and you're not isolating the sigmoid sinus, so you cannot posteriorly transpose the sigmoid sinus. And therefore, we have now studies that show that we are losing about 15 degrees of exposure by the fact that you cannot do a posterior transposition. But then you can always convert it to an open petrosectomy kind of dural incision, in which case you don't have to lose it if you do need it. You need to also look at the anatomical variations. You need to look for tentorial venous lakes, venous variations like the labae draining directly into superior petrosal sinus, which in that case would be a contraindication. Then you need to study the entry point of the fourth nerve under the tentorium. Show you a small clinical
This
video
demonstrates the anterior petrosal intertentorial.
Yeah, this is a small video showing the anterior petrosal variant of the intertentorial approach. 32-year-old male patient came with, this was the tumor, a chordoma, anterolateral petrous apex and petroclival region chordoma. So that's the approach that we did in this patient. And that's the incision that we need for this particular kind of anterior petrosectomy. And there you see the steps of the anterior petrosectomy. So there is the foramen spinosum. You need to identify the middle meningeal artery properly, ligate it, coagulate it, and cut it. And it should be cut without a stump bleeding so that it doesn't disturb your surgery. And then the key is to go and localize the GSPN. And that's the stimulation that you need to do, and look for facial nerve stimulation there, because the GSPN can be a bad deficit with a dry eye. And that needs to be clearly identified, protected, and the dura on the other side developed so that you get access to the Cavase triangle. That's the projection of the internal artery canal that you saw there. Once you have identified your borders, you have the third V3 here. You have the carotid within the petrous bone there. And that's your anterior petrosectomy that is being slowly done. And there you will see the posterior fossa dura. Once you reach that, it's better to open the posterior fossa dura a bit so that the CSF drains and then you get brain relaxation. Then you identify the superior petrosal sinus. And then, like I told you before, we need to split that into two layers. So this is the V3 here. So we generally start the intertentorial dissection near the V3. Once you get into that plane, then it becomes quite easy. Basically, it's an incision parallel to the superior petrosal sinus. Once you find the two layers, then it becomes progressively quite easy. If there are any venous bleeding, like you can see here, you just need some flow seal or some hemostatic material, and you just pack it and see. Once you'll see as we go along, you keep cutting, prolonging the incision parallel to the superior petrosal sinus, and that's a little bit of gel foam into a small venous lake, some glue there, and there you can see how the layers are being developed. And so you have here, and what stands out in the middle is the superior petrosal sinus. You have the PFTL and the TTL now, the two layers that are well exposed. And there we are just trying to do a navigation to see how close to the superior, to the tentoral hiatus we have reached. So we know there is a few more millimeters to go. And there you have now the three duras. You have the posterior fossa dura, and that's a ligation of the superior petrosal sinus, and which can be cut. And then in this case, we decided to only open the PFTL and the posterior fossa dura, but that was enough for us in this particular case. The temporal lobe was completely covered during the entire part of the surgery, and directly you can see without any brain, you're right on the tumor in the petroclival region. Fortunately, this tumor was the consistency was pretty good for us, so we could remove it with no major problem. And there you see the tumor coming off, and that gives you access. After that, you will progressively see the basilar artery. And here you can see the opening anterior transposition of the fifth nerve. So that's your fifth nerve here. You just open that, it gives you an access superior to the fifth nerve as well, so that you have access to the entire tumor. So as we keep moving this tumor off, you'll see the entire basilar and see, that's the basilar artery, and you see all the branches of the basilar artery, the anterolateral surface of the brainstem there. We had to take it off the sixth nerve, and then we got a very good excision, and that's how you close it. You put some fat there and you put some glue, and that should take care of the problem. There's an immediate post-op scan, and then we repeated the scan a week later. He had a partial sixth nerve palsy, which fortunately completely improved. The V2, V3 hypoesthesia, that also improved. By 3 month follow-up, he had completely improved. And there you see there was a very small bit here onto the Dorello's canal. That was the only part of the tumor that we did not remove for fear of injuring the sixth nerve. And this shows you the APIA variant. That means anterior petrosal intertentorial variant. So that's the patient post-op. You can see that the sixth nerve has completely improved. Yeah, and the seventh nerve is also preserved. So the patient had a very good outcome. Now, this is not just that. It's not just an extraaxial lesion. It also gives you the opportunity for intraaxial lesions. Now, most centers today, you have a tumor of this region. Most centers would do a transcortical approach. But what's the problem with transcortical approach for these kind of mesial temporal lesions is the fact that you have a lot of fibers here. You have the IFOF, you have the ILF, you have the arcuate fasciculus. These are all covering the tumor, and you have to at least go through one of them to reach the tumor. Now, you could use this approach even without a petrosectomy, just have to go subtemporal, but follow all the same principles which I described to you. But in this case, you would open the TTL, the temporal tentorial leaf, and you would leave the posterior fossa alone. That will get you to the region, the mesial temporal region, that is the fusiform gyrus and the parahippocampal gyrus and the hippocampus, and you can remove the whole tumor. And this post-op DTI shows that all the tracts have been preserved and the tumor has been removed. So these are the advantages of these approaches. So petrocell approaches, I think we should not be too dogmatic about the surgical approach. They are valuable strategies if properly mastered, needs cadaver dissection training, and we can tailor the approach with these new variants, either a combined petrosectomy intertentorial, anterior petrosectomy intertentorial, or a epidural subtemporal intertentorial approach. So these are the three variants that we have recently described. I thank you very much for a patient listening. I'm open to any questions or comments.
Yeah, Roy, thank you so much. It's been a very elegant presentation from first principles to advanced, and I certainly appreciated it very much indeed. I hope, and I'm sure our audience also. So at this point, I will see if we have any questions in the box, and I will ask the help of our moderators here to see if they can have been monitoring any questions have been coming through.
Not yet. There aren't any.
Any comments from Professor Otani? Otani Sensei, you have any comments?
Yeah, thank you. Thank you. So, Professor Roy Thomas, so you are good presentation and you have good idea to dissect the intertentorial. So, would you please let me know the surgical tips to dissect the tentorium? So it's I think it's very difficult to dissect so precisely. So how do you confirm the two dural layers? So the interdural layers. So
thank you for your question. We actually we did many cadavers before we perfected the technique. And the key is to expose the superior petrosal sinus. So a little bit the anterior or combined petrosectomy gives you a beautiful exposure of the superior petrosal sinus. Once you have the superior petrosal sinus, you just have to cut parallel to it, maybe 2 or 3 millimeters away from it, and you not full thickness, half thickness, so that you get between the layers. So it is exactly the same technique that you would do when you cut the meningioorbital band and develop the lateral wall of cavernous sinus. So it's exactly the same technique. So whatever you do for the lateral wall of cavernous sinus, if you do for the superior petrosal sinus, you will easily find it.
But I think it's very difficult to dissect the patient in cases of the dural sinus is very developed the patient. So have you ever experienced big venous bleeding from the intertentorial sinus? So
yeah, well, I've never had too much bleeding. I've had a few leaks, but that stops very well with flow seal or gel foam. So that's not a problem. But yes, I appreciate your point. Venous leaks can be an issue, and that needs to be looked at. And if you encounter it, just put some hemostatic material into it, and you can continue your dissection next to it.
Yeah, thank you. So, but so you finally you cut totally the tentorium, cerebral tentorium. So what's the purpose of the dissect intertentorial layers? What's the main purpose for the surgical procedures?
Yeah. So for a lesion of the petroclival region, which is what we are going to do this approach for, you can keep the temporal lobe covered completely during operation. The temporal lobe is not seen. The vein of Labbé is not seen. You don't see these structures, so you do not damage them at all.
Yeah.
And then if you're doing a mesial temporal lesion, you keep the posterior fossa completely covered while you open the TTL, the temporal tentorial layer. So what you need to see, you open, and the rest you keep covered.
Yeah, thank you so much.
So
Okay,
let's
thank
go.
you.
Thank you, Naoki. It's very useful to have questions from expert to expert. Question from Ben, and then we'll ask Professor Karagözov for his commentary as well. Ben?
Yes, thank you. Thank you, Professor Daniel, and it's a pleasure for me to listen to your lectures, and it's very useful for me because I also specialize in scalp-based surgery. I would also like to follow with Professor Otani's question. So I try to ask for some tips. So in your intertentorial approach, so in case of say petrocephalus meningioma with both infratentorial and supratentorial portions, so in during the initial phase, how deep do you speed the tentorium? How much you need to speed the tentorium, and at what stage you cut the superior petrosal sinus, and at what stage then you will excise the tentorium? So
That's a very good question. Now, this approach is fantastic for let's say something within the cistern. It's very good for the cavernomas of the brainstem. It's very good for chordomas. Now, in meningiomas, it may be limited depending on how much of the tentorium gives attachment to the meningioma. Now, if the meningioma is only attached to the temporal tentorial leaf, then you will be able to do this approach. Or if it's only attached to the posterior fossa tentorial leaf, then you will be able to do the approach. But if it has attachment to both leaves, then this approach cannot be done. So it depends on the primary attachment of the meningioma. If the attachment is primarily to the petrous bone, then you can do the approach. But if it's got a major tentorial attachment to both layers of the tentorium, then this approach, I'm sorry, cannot be used. But it is the same. You will still do a petrosectomy. You'll try to reflect the layers to find out how much of attachment is there. If it is attached to both layers, then obviously you have to remove it and you will not be able to do the splitting. So you'll have to do it like a classical petrosectomy in that situation.
I see.
Thank you, Roy.
May I ask a question,
You have
please?
a question from George? Yes, of course.
Yes. Thank you so much for that very fascinating talk, Roy sir. I noticed that for the in vivo intertentorial approach, perhaps you used the 15-number scalpel blade. So is that what you prefer, or maybe is there a role for a more sharper 11-number blade or a micro scissor? And what is the ideal instrument you would use for a cadaveric dissection, where you get this dissection perfectly right?
I think 15 or 11 would be the best.
Okay.
Yeah.
And one of the contraindications you had suggested was perhaps an anomalous vein of Labbé, which drains directly into the superior petrosal sinus. So would it be better to always be armed with a pre-op venogram, or are there some ways to identify it intraoperatively if we have missed a venogram?
No, I don't think we can miss a venogram if you're planning on this. We need to do a good MR venous angiogram, which shows the trajectory of the vein of Labbé and to find out where it is draining. So that is an absolute essential thing.
Thank you. Thank you very much.
Great discussion so far. But maybe it's the perfect opportunity to ask our colleague Konstantin for his commentary. And maybe worth highlighting, Konstantin, that you originate from Sofia, which is where the next EYNS Congress will be. And actually there will be a joint ACNS EYNS Young Neurosurgeons World Symposium. So over to you.
Thank you. Thank you very much, Professor Dimitriadis. It was really very nice and very instructive presentation from Professor Daniels. Our stage of skull-base surgery has evolved actually in the so-called spaces that we are creating during surgery, because at the beginning we were just using the existing and potential spaces. Now, first removing bone, now we are dissecting dura. That we started with the orbital band, and then we continue with feeding dura over the cavernous sinus. And this is probably, I think, the most refined of the methods that I have seen about creating spaces through dural splitting and dissection. Well, I definitely will say that it is very important that dura that we are going to be working on is not involved by any of the pathology. Otherwise, the method has to be modified significantly. That is my impression of the techniques that have been shown. Also, definitely meningiomas and particularly highly vascular lesions may interfere with the proper execution of that. The technical points are, one is about the superior petorsal sinus. In fact, we have at this point of joining the tentorium probably 4 dural layers. And these 4 dural layers, somehow, I think we can dissect in a way that the superior petorsal sinus can go probably down to the posterior fossa layer. So I would like really to ask about that. Is this a standard technique or something like that? That's what I noticed. And also, it's another point. What is the best point to evacuate CSF so we slack the brain? Definitely at that point, we cannot use more navigation, but in skull-base surgery, we have the structures fixed, so navigation is not so dramatically important at a certain moment. I would like to ask about these 2 points. The separation of the superior petorsal sinus from these layers, where it should go, and then about the CSF evacuation.
Okay. I think I've understood your questions. You raised very important points. One is that this procedure may be possible to do it or needs to be modified in meningiomas. There's no doubt about it. So if the tentorium is involved by the meningioma, then obviously this approach will be converted to a standard petrosectomy approach, and the dural openings are based on the attachment of the tumor. Now, opening of the CSF, the best place to open the CSF to start with, as I showed in my video, is to open it in the posterior fossa so that you get CSF coming out and brain relaxation. And then the dural opening is tailored based on the requirement. So if you need to look at the anterolateral brainstem, then you just need to open the posterior fossa tentorial layer, cut the superior petrosal sinus and connect it to the posterior fossa. If you want to look at the parahippocampal gyrus, then you have to do only the temporal part of the incision and leave the posterior fossa alone. Now, the superior petrosal sinus is always ligated in every petrosectomy approach, and the tentorium is opened in every petrosectomy approach. So that it is exactly like the classical petrosectomy approach, and there's nothing new in this approach as with respect to the division of the superior petrosal sinus. I think, have I answered your questions properly?
Exactly, yes. These were the 3 points that are actually raised. Thank you very much. It was very adequate. Thank you.
Yeah, I'm glad that we have a whole plenary session in Sofia organized for petrosectomies. This material and some more other material will be presented in the plenary sections, and I look forward to the Sofia conference and to meet you.
Yeah, hopefully. Yep. Thank you very much. Thank you.
This is a fantastic point to move to the next talk. But firstly, let's thank again Roy for this very methodically presented.
Can I ask one question?
Okay. We can go back to one last. Roy, can you take one more question?
Yes, Professor Mathuria. Yes, for sure.
Excellent approach, protecting the temporal lobe with the dura so the retraction changes are not there post-operatively. No doubt about it. Only thing I wanted to know is that Are there any additional advantages with this approach for the basilar aneurysms over the approach classical, which is described by Professor Kawase?
It's exactly the same. The only difference is that you're protecting the temporal lobe. So you don't have to see the temporal lobe at all. But otherwise, the approach is exactly like previous classically described, I don't know, 50, 60 years back. Yeah.
Yes, yes, that's true. Somewhere in 80s, actually.
Yes.
Yes.
Well,
Thank you. Thank you.
Thank you.
Co-resident of Prof. Kawase, Professor Hirotoshi Sano is with us. If Sano Sensei wants to say something, Sano Sensei, would you like to say something?
No, sir. Thank you.
No, Professor Hirotoshi Sano, I can see his name in the attendees. Maybe he is driving or something, maybe. Please carry on.
Okay. Let's not risk the driving.
Yes.
If there are no more questions, can we check? I can't see any. No. In that case, thank you again, dear Roy. Very methodically presented case for a complex and exciting topic, and we look forward to more discussions in Sofia. Now it's again quite a pleasure to introduce a young neurosurgeon as the next speaker. 𝒁𝒂💏 𝑏𝒂𝒏 is from Bangladesh, who is also spending some time in Japan and is going to talk to us about STA-MCA bypass. So 𝒁𝒂💏, over to you. Thank you.
Thank you, Professor. Thank you. I'm going to share my screen. I hope you can see my screen.
Yes.
Yes. Thank you once again. Most esteemed patron of today's webinar, Professor Yoko Kato Sensei, respected moderator, distinguished speakers, discussants, and August gathering. Assalamu alaikum. Good afternoon, good evening, and good morning to each and everyone from different corners of the world. I welcome you all to my presentation, that is the STA-MCA target bypass through mini craniotomy in chronic steno-occlusive disease. It's actually a case report. A brief about myself. I'm Dr. Mohammad Shahnawaz Biswas. I'm fellow from Fujita Health University, Bantane Hospital under our beloved Professor Yoko Kato Sensei. These are few group photos while I was staying in Fujita Health University from February to April. This is my graduation photo in last April. And presently, I'm working in National Institute of Neurosciences and Hospital, which is located in capital of Bangladesh and is the largest neurosurgical referred center in my country. So without further addition, I'm going to start my presentation. Cerebral bypass. Cerebral bypass brings about benefit to patients by immediate improvement of blood supply to the affected part of the brain. It is widely practiced, and among all the cerebral bypass procedure, the STA-MCA bypass procedure is very famous and widely practiced throughout the world. So what are the purpose or indications for which we do the cerebral bypasses? The main purpose is two. Number one is the flow augmentation, and number two is the flow preservation. The very common example for flow augmentation is the moyamoya disease, and one of them is the chronic steno-occlusive disease. And another purpose is the flow preservation, like in aneurysm surgery, like in cavernous IC aneurysm. If the flow diverter is not affordable, is not feasible, in that case, we have to go for bypass. And also, rarely in tumor surgery, if it involves the parent artery. So again, the cerebral bypass can be of different type. Like it can be a direct bypass, as I have mentioned, the STA-MCA is a direct bypass. If we use the saphenous vein or radial artery as a interposition graft in high flow bypass, which is also a direct bypass. It can be of indirect bypass like the EDAS, which is done in moyamoya disease. It can be of combined bypass, direct or indirect. Again, there is a variety, low flow, medium flow, and the high flow bypasses. However, if we talk about the bypass, we must talk about the history of cerebral bypass. And we all know the renowned neurosurgeon, Professor Yasser, who has revolutionized the cerebral bypass procedure. He is the first neurosurgeon who did the direct and successful cerebral bypass back in 1967 in a patient with Marfan syndrome. Afterwards, it is a revolution in vascular neurosurgery. So for any bypass procedure, if the decision is made for the bypass, for better bypass, the pre-surgical image evaluation is very important. Conventionally, in standard bypass procedure, CT angiogram or MR angiogram or DSA or a combination of them is usually used for pre-surgical planning. But very less frequently, the fusion images are evaluated. I mean, the fusion between CT, MRA, and DSA for better pre-surgical planning. So in conventional bypass, STA-MSA bypass procedure, the scalp incision targets to harvest the whole STA length because the recipient is not preoperatively determined. It is rather determined on the field. That is why this incision becomes bigger. The craniotomy is also bigger, and it is not less invasive. So what's new here in my case report and also a few works done in Japan is that for pre-surgical evaluation, we have used the fusion image, the fusion between different modalities of images, the CT angiogram, MR angiogram, 3D CT, and digital subtraction angiogram. With the help of two important software, there is the AMIDA 3D visualization software, and another software is the GeoStation software. So what it benefited us, in many ways, like the exact location of the STA with appropriate length, so we can tailor this incision as well. The exact location of the recipient in close vicinity of the STA and exact location and size of the craniotomy can be almost 100% determined preoperatively. So which as a result reduces the surgical footprint. So here, this is the AMIDA software. You can see this is the CT angiogram with the 3D bone with superimposition of the STA. And this is the fusion image. The fusion image, it exploits the benefit of MRA for the brain, sulci, and the gyri. Then CT angiogram for the STA, and the venous system, and the green one is the arterial system, which has been produced from the digital subtraction angiography. So you can see this is the closest vicinity between the donor STA and the recipient of the M4. So there is the location of the craniotomy for the STA-MSA bypass. So this is only AMIDA software. This is the post-operative image of previous study. You can see the patency of the bypass here, the bypass site, STA. The green is the recipient. And you can see the 3D reconstruction, the bony gap for the introduction of the STA into the cranial cavity. So it is the use of the AMIDA software, and we have used also the GeoStation as the supplementary software for check and balance between the AMIDA and the GeoStation. So in our case report, our patient was a 75-year male presented with right-sided weakness. It was a chronic onset. The CT angiogram showed the M1 occlusion. The DSA also showed that, but there was pile supply towards the MCA territory, which was scanty. So we have utilized the AMIDA and the GeoStation software for this STA-MCA bypass procedure with a very minimal invasiveness and target mini craniotomy. Here you can see the diffusion-weighted image of this patient, which shows the watershed infarct at the left SCA and the MCA territory. That means there is reduced supply of blood. If there is a hypertension, there will be recurrent stroke, as patient already had 𝑘/s. This is the CTP. The cerebral blood volume is almost normal at the left MC territory, but the cerebral blood flow is markedly reduced. So the mean transit time is very high at the left MC territory, and the time to peak is also very high at the left MC territory. This is the CT angiogram. You can see from the distal part of the M1 and beyond, there is no vasculature visible. So patient underwent the ST-MCA bypass procedure on the left side, and preoperatively, all the images, the DSA, CTA, MRI, and MRA has been fusioned with AMIRA, and the only CT has been used in 𝒌 software for the planning purpose. Here, in my case, you can see the 3D bone with superimposed STA. This is the closest view. Here it is the AMIRA software. You can see it can show the scalp. It can show beyond that. And the green one is the arterial supply. This is the motor cortex. This is the central sulcus. So it also beautifully shows the relation of sulci and the gyri with the recipient. And this is the closest vicinity. The red one is our donor, that is the STA. So this is the location of our craniotomy site. So we supplemented it with the 𝒌 software, which only uses the CT angiogram. This is very easy, but it lacks the vision of sulci and the gyri. So it only uses the CT angiogram. This is the STA. This is the virtual craniotomy, and inside the green one is the cerebral vessel, but it doesn't show the sulci and the gyri of the brain. So it automatically measures the our expected length of craniotomy and how much STA is required. So how much STA incision over the STA should be given. This is the position of the patient on the left side. Patient is positioned, as you can see, on the right lateral position, the ipsilateral shoulder on the left shoulder. As we used to do it in a sitting position. So we also, the height of the bed is suitable for a sitting position. So the skin marking, we don't go the incision up to, don't take the incision up to the root of the zygoma, because we have measured with the 𝒌 software, and preoperatively before incision, we again confirm it with palpation and Doppler, percutaneous Doppler. This is the skin incision with the harvest of the STA over the temporal muscle then we keep the STA intact. We cut the temporal muscle, retract posteriorly, and mark the craniotomy, which is almost less than 3 by 3 centimeter. Then just before craniotomy, we put temporal clip, proximal and distal part of the STA, and resect it and keep it with papaverine cottonoid outside of the field. Then do the craniotomy, sometimes with 1 burr hole, sometimes 2 burr hole. The location of the burr hole is, if with the bony relation, is 4 centimeter above the root of the zygoma. With the 2 burr hole, we make the craniotomy, which is marked previously. Then after durotomy in a crisscross fashion, we do ICG video angiography, and this is our preoperatively targeted recipient, and this is the central sulcus. Then bypass bed preparation. Preparation of the donor with the removal of the adventitia, fishmouth preparation, and heel and toe stitch. Then afterwards, you take the donor, just like the usual bypass practice, at the bypass bed. Then we put the temporary clip over the recipient artery. We do the arteriotomy and heparinase wash. Then we first anchor the heel, toe, then interrupted fashion. We use interrupted fashion for the anastomosis. After the bypass has been done, we checked with Doppler and also ICG video angiography. You can see nice patency. This is the distal flow. Then afterwards, the dura is closed, and with keeping a cap for the STA introduction into the cranium, and the scalp is closed with the bony fix in a mantillayer fashion with a subgaleal drain. So all has been included in a 1 minute 20-second video. I would like to take the privilege to show the video. This is the MRI of the patient, the CT angiogram of the patient. This is the AMIDA software, the gyrostation software, position of the patient, the skin incision, then the STA harvest under microscope, temporal muscle retraction, craniotomy marking, then preparation of the donor, the craniotomy, durotomy in a crisscross fashion. Then before arachnoid dissection, we go for the video angiography, then target arachnoid dissection over the recipient, preparation of the recipient and the bypass bay, preparation of the donor with heel and toe stitch. Now the temporal clip over the recipient, arteriotomy. Then the completion of the bypass. First heel stitch, toe stitch, then interrupted stitch. Checking with IC video angiography, checking with the Doppler. Afterwards, the closure is done. However, post-operatively, on the third POD, we do the CT angiogram and also the CTP. It is a nice patency of the STA. This is the bypass. This is the STA going through the small opening of the craniotomy into the intracranial cavity. The CTP is very excellent of this patient. The cerebral blood volume bit improved from the previous status, but the cerebral blood flow has markedly increased with reduction of the mean transit time and reduction of the time to peak. It's a very expected result in such case. This is a comparison between the preoperative CTP and the postoperative CTP. You can see very nice change. So in the discussion, the STA-MCA bypass brings about blood from the extracranial cavity to intracranial circulation, like in our case, to the M4. And it bypasses the lesion, like in our case, the M1 stenosis. But for a successful bypass surgery, 3 techniques is very important as a young neurosurgeon. One is the excellent harvest with appropriate length of the donor, that is the STA, the dissection of the recipient, and exact localization of the recipient, preferably preoperatively, and the main anastomosis. Very flawless anastomosis, either interrupted or continuous. So whether in steno-occlusive disease, the bypass is beneficial to medical treatment or not, sometimes it's a debate. But the Japanese ECIC trial, the JET study, it is the version 1, which has shown the validity of the STMC anastomosis in steno-occlusive disease to prevent hemodynamic stroke. And in the JET study 2, they have also mentioned that if the cerebral blood volume is less, the cerebral vascular reserve is less, the bypass is very beneficial compared to the best medical treatment. However, the validity of the STMC bypass can only be secured under condition of high patency rate, low procedural morbidity. Therefore, reliable and minimally invasive surgical planning and procedures are required, for which preoperative surgical planning and evaluation is very important. So conventionally, in standard STA-MCA bypass procedure, as I have mentioned, that most of the time, in most of the corner of the world, only CT angiogram or MRI angiogram or DSA, or sometimes a combination of them are used for pre-surgical evaluation, but not a fusion image, not any virtual imaging. So in standard STA-MCA bypass procedure, the scalp incision depends on mostly the parietal branch of the STA. As the recipient is not determined and localized preoperatively, the scalp incision is very big to harvest the entire STA. And also, the craniotomy is very big. Sometimes it is a trional craniotomy with the Sylvian dissection to find out appropriate M3 or M4. So which is not less invasive. Therefore, the standard method does not align with the principle of minimal invasive neurosurgery, which involves minimizing the surgical footprint to create a small but adequate exposure for a safe and efficient procedure and with minimal or no neural tissue retraction. So this is we expect. So the journey towards minimal invasive bypass, STMC bypass surgery, there are many articles. This is a very nice article published in 2006 by Kirota et al., who used the PET scan to check the cerebral blood flow. Like in this picture, in the right frontal lobe, the cerebral blood flow is reduced. He also used the MRI and MRA for the location of the donor and the recipient. And he has used all these images in navigation, neuronavigation. And here the target site of bypass in his article. Like this is a 3D bone with the navigation probe. This is the MRI. This is the PET scan. They have targeted the right frontal lobe. So the craniotomy size is a bit larger. With the skin incision is very larger. This is the bypass. They have done the bypass. But the invasiveness is a bit large, quite invasive surgery. But in our case, which I have shown that the craniotomy is only 3 centimeters. The skin incision was approximately 6 to 7 centimeters. It's a very linear incision. The muscle injury is very less. The cranial size is very less, and we have exactly localized the recipient for a perfect bypass with the help of AMIDA and gyrostation software. So another article towards minimal invasive STMC surgery, which has been published by Nakagawa et al., the virtual surgical planning for superficial temporal artery to middle cerebral artery bypass using 3-dimensional digital subtraction angiography. This sensei has used the 3D DSA for STMC bypass. Here you can see this is the 3D bone with STA. This is the 3D angiography, the location, and this is the virtual placement of this information over the patient's scalp with the help of Leonardo workstation software. This is also a very nice study. But what was the main problem? Main problem is the bypass has been perfectly done. It is the donor, this is the recipient, this is the bypass, and the post-bypass images, very excellent, very small craniotomy. But the main problem was the less proper visualization of the recipient and cerebral sulci, which we can easily and nicely see in AMIDA software. Another study was done by the Fisher et al. Towards a target mini craniotomy for STMC bypass. He has utilized the MR angiogram with 3D CT with the help of dextroscope. It's also a virtual software like the AMIDA, but a bit different one. Here you can see the MRA shows the STA, then the recipient. This is the virtual placement of the information, the virtual craniotomy, and all has been placed virtually with the help of dextroscope over the patient's scalp and the measurement of the STA harvest. Again, the problem or the drawback of this technique was the less conspicuous identification of small appropriate recipient. If there is very small recipient, then it is very difficult to visualize with this technique. But in AMIDA, it's small to small recipient you can see. So in STMC bypass procedure, we expect minimal invasiveness because it reduces morbidity in many ways. It reduces the temporal muscle atrophy, facial muscle weakness, and less scar formation. Conventional or standard turinal craniotomy for STMC bypass. But the disadvantage, also it has a drawback that the AMIDA and the gyrostation software, you need to acquire technical nuances to make the fusion. And it's not widely available in each and every corner of the globe. But hopefully in near future, it will be available. So in conclusion, the STMC bypass is an effective treatment for symptomatic chronic cerebral steno-occlusive disease. In this regard, the preoperative planning of donor selection with required length, location of the recipient, bypass site, location of craniotomy, and skin incision accordingly are very important for minimal invasiveness. In this case report, we have been able to demonstrate a target bypass with mini craniotomy with the help of AMIDA 3D visualization software, and which has been supplemented by the GeoStation software. These are all the references for my case report. You can go through. And at the end, the premises of Fujita Health University Bantan Hospital under Professor Yokokato Sensei is a remarkable event for me. Actually, it's a game-changing for my attitude, skill, and knowledge. So I want to express my gratitude to Professor Yokokato Sensei and arigatou gozaimasu, each and everyone, for your patient hearing. Thank you.
Thank you so much, Dr. Biswas. Thank you again. It's been a very well presented, clear presentation, and very educational. Thank you for pulling together so much information. So we'll go to questions, and Ben has the first hand up.
Yes, thank you, Dr. Biswas. Arigato for your presentations, and it's a really nice one with the demonstrated, and also I can see the inspiration that you get from the Professor Kato, and it's really inspiring talk to the young neurosurgeons. So I concerning your case, I have some questions concerning that. So because I have experience in reading I have some experience in reading the angiogram for those, for example, in chronic occlusive disease patients or in more and more patients. So in when you consider the imaging to fields for pre-op planning, so what is your recipe? The mortality and the model of the MRI, the quality of the MRI, because sometimes in advanced stage of occlusive disease, some measures, some arteries might not be shown up in the CTA and MRA, or sometimes there will be venous contamination from the vessels. So it turns out that sometimes when you open is the vein instead of the artery.
Artery, yeah.
And, as shown in the MRI. So in order to fuse with your station for correct planning, so what is your tips? What's the recipe that you?
Over this, I have worked with a very expert radio technician in Fujita, Takeda Sensei. He used the MRI for sulci and gyrus. He used the CT angiogram for location of the donor, that is the STA, and DSA for venous and arterial system. And he fuses it. So what it benefits, it can differentiate between the venous and the arterial system. And it is a chronic steno-occlusive disease. So actually, the vessels remain. There is a shift of the vascular territory. Like from the STA to the watershed also shifts inferolaterally. So with the AMIDA, that is why I say that the AMIDA can detect the smallest recipient perfectly. And this is definitely the software, but paraoperatively, your judgment is very important.
I see. So in case that so let's say you have some uncertainty concerning the angiogram. So how do you modify your wound in order to achieve the minimal on the approach?
Yeah, actually, yeah. Like if you see the skin incision, mostly it is linear, but sometimes we extend the incision just 2 centimeters posteriorly. In case I have missed my recipient with my target craniotomy. So I can easily extend downward, upward, or anteroposterior.
I see. Thank you.
Thank you, Dr. Biswas. Professor Suresh?
Yes, sir. Say, Dr. Biswas, Shahnawaz, excellent presentation, and
Thank you, sir.
say one thing about steno-occlusive disease. Long time back, maybe 30 years or even prior, it had been told by Professor James Osman that bypass has got a tremendous role to play. Only thing is that there are other things which had come up, and the medical conditions and medical therapy and those things have taken over because of some other reasons. But technically, and the ultimate achievement is quite a great with this, which he talked about the oration which he delivered in, say, the respect of Professor Routh in Cerebrovascular Society of India conference also. Say that about your technique, as you have already declared, it's a question to your declaration only, that AMIRA bypass, AMIRA software, where it is available and how costly it is, because the reason is, it's not only in this condition. There are so many other reasons in which we can utilize this software to do the surface marking. It's an excellent thing. So you tell us the availability and the cost.
Yeah, sir. You have well mentioned about it. Actually, we often ask our Professor Yokugata Sensei. The AMIRA is a Japanese software. You have to purchase it one time for lifelong, and the cost is in Japanese yen. It is I mean, in Bangladeshi taka, it is 10 lakh. In Indian rupee, it could be 8 lakh. That means the close to 1 million. So it's a one-time purchase, quite high. But the main problem is it is still within the territory of the Japan. It is not beyond Japan. I hope they will extend their hand to other countries as well.
Can it be shared with amongst the other institutes in India? Say, if we purchase it for one institute, then can we share it for the other institutes in India?
Maybe it's not possible, because it's just like your laptop. You have your laptop where you buy, it is fixed with your identity, just like and well said, sir. It is very much used in trigeminal neurology, vascular decompression. It's so beautiful, sir. You just can easily see.
No, there are so many places where it can be utilized, where you want to do a surface marking and craniotomy. It's excellent.
Excellent.
Very nice. Really pleased.
So one question from George, and then the comments from our discussants.
Thank you. Shahnawaz, it was a fascinating talk. I really liked it very much. Just a small question, in some situations, especially in pediatric bypasses, you have very small diameter vessels where actually on table, you might suddenly decide that this is not suitable for a bypass. So this diameter is just too small, and I would go for an indirect procedure, revascularization. So has the Amarin software helped you with a pre-op decision to avoid an intra-op decision making in this? And the second question is, sorry, please go ahead. I'll come back to the second question. No, please go ahead with your answer.
Actually, Amira, through our very limited experience in Fujita, I have seen that we have also done it in Moyamoya disease. It can detect very tiny vessel preoperatively. And the best thing is with the relation of the gyrus and the sulci. So a very high chance of detecting that small vessel. And yeah, definitely, like in Moyamoya disease, the vessels are very narrow, and sometimes the arteriotomy is not possible. So you have to take decision, as I have mentioned, preoperatively, that if it is not feasible to do bypass, then you have to go with the indirect one.
Right, and thank you. The second question I had is that though I'm not an experienced bypass surgeon, my question may sound a little preposterous. One of the problems which I have seen with especially beginner bypass surgeons is that they struggle with redundant length of the vessel. At the same time, sometimes they, they have short vessels where they really need to struggle to, approximate. So is there some way where, this software could help us avoid that or plan it better?
Yeah, when we use it virtually, it shows the total course of the STA. I mean, if it is tortuous, it will show like that. So if you think that you have given a 6 cm incision of the STA, and when you harvest it, it actually goes beyond 7 centimeter. So as a beginner, like I'm also a beginner, so I think at least 2 or 2.5 centimeter extra length is safer, because I have to go for the preparation of the donor. That means I have to, when I do the fish mouth preparation, I may lose half a cm from the donor. So it's better to keep, but it should not be very tortuous, because the more the length of the donor, there is a more chance of post-operative failure of the bypass.
Thank you, Dr. Wiswas. Let's ask Professor Otani and then Professor Karagiozov for their commentary.
Yeah, so only just one comment. So in such, thank you for your good presentation. So my opinion is in such a wound trouble, so hyperbaric oxygen therapy, hyperbaric oxygen therapy is very, very effective for the early stage of the wound trouble. So please try this therapy in such cases.
Especially in pediatric cases, sir. If there's a like in myoma disease after harvesting, sometimes there is a ischemia of the own. In that case, can we also go for the hyperphagia?
Yeah. And one question. So in cases of in mini craniotomy, surgical field on the anastomosis is so small and deep after the CSF releases. So I recommend you so the field to the anastomosis is to become the shallow, shallow. Yes. So how do you think about that? So do you make the surgical field so to shallowing the
actually, sometimes, especially in chronic steno-occlusive disease, what I have seen, after arachnoid dissection, there is CSF drainage and the brain very subsides and the field becomes very deep. So in that case, you might have to sacrifice very small vessel from the recipient underneath so that you can raise it. You have a raised bypass plate and continuous suction with 6 French or 8 French small feeding tube. This is helpful.
Okay. Thank you for your good. Yes,
I'm still young, very young, sir.
Yes, I also so I agree with your opinion. So surgical indication, strict surgical indication, and so good technical to anastomosis. So please continue the training.
Yeah. Thank you, sir.
Thank you so much.
Konstantin, you have the final word before we move to the next talk?
I understand the constraint of time. Just congratulations for the excellent analysis, how to minimize craniotomy. We do it probably with the fusion of MRI, angio, and navigation. That will actually mimic again what has been achieved. I have just very few questions. Number one is the point of the positioning of the donor regarding the recipient. Do you orient towards the central flow, central or peripheral in such kind of cases when you are targeting the motor area? Because this is a point which creates hemodynamic conditions which are very different. And my second point is, in fact, do you really measure the flow, which this donor will bring, at least initially? Why I'm saying that? We have an CA stenosis, which is having, border shed the ischemia. So practically the central hemodynamic conditions will attack the whole flow. As I saw your post-operative angiography, actually, we don't have peripheral flow. We have only central flow. So that is a very important point for the planning of an anastomose. If you have any comments, please let me know, because it's a very important point.
Sir, actually, quantitative measurement before bypass and after bypass perioperatively, we haven't done it. Just qualitative with video angiography and the Doppler ultrasound. But we can do the quantitative assessment before and after the bypass. This is number one. And number two is, sir, we orient the recipient and donor in such a way that for a right-handed surgeon, it becomes easier to do the bypass, like 10 to 4 o'clock or 2 to 10 o'clock, 8 o'clock. This is very important. If I cannot place it like that, I may have to change my sitting table or my location so that I can orient in this way. But as a young neurosurgeon, this is very important for the bypass, doing the bypass.
I understand. Thank you very much. Thank you very much.
Thank you, sir. Thank you.
Thank you again, Dr. 𝒂𝒏𝒔, for both the presentation, but also the discussion. So it's very promising, and we look forward to further presentations in the future.
Yeah,
now
sure.
Now we will move to the third talk of the day by George Villanilam on the corpus callosum. So, dear George, go ahead.
Please unmute your mic, Prof.
Please unmute.
Yeah, I'm sorry. I hope you can see me and hear me now.
Yeah.
Yes.
Yes.
Yeah.
Share your screen.
Yeah.
Please go ahead.
Thank you very much, Professor Andreas, for that wonderful introduction. We are moving on from two very, very fascinating talks by Professor Roy and Shahnawaz. And as you know, perhaps as neurosurgeons, we are not so much, this is a less glamorous part of neurosurgery, the corpus callosum, because as neurosurgeons, you know, we like what looks red and what is, you know, what really challenges your bravado, what can bleed on your face. So this is not something like that. And sometimes we try to push the callosum away to our colleagues in the Department of Neurology because we think that it is their part of the brain. Let me begin by very, very profusely thanking Professor Yoko Kato, Madam, for your fascinating and you know, painstaking efforts under the mentoring both Dr. Liu and Dr. Raja to run the ACNS courses throughout the COVID time. And even after that, the energy and the effort that you put in is absolutely fascinating. And the generations of neurosurgeons who have benefited from these talks, both directly and indirectly, seeing it later on, I think we can't keep a real count of that. Thank you very much for that. So I have, you know, I've kept this talk very, very light because we are already, you know, recovering from a lot of brain strain through heavy talks and heavy neurosurgical topics. So I'll keep it very light, and this is the agenda that I would be going through. First, a bit on the anatomical perspectives, then a very, very functionally unique structure is the corpus callosum. I'll just tell you about a few radiological tidbits. And as surgeons, perhaps nothing is complete till we actually see it on the surgical table. So a little bit about its surgical significance. And then there is a lot still unexplored about the callosum, which I would like to take up when I present the end of my talk. You know, this is an absolutely fascinating part of the brain with 200 million myelinated nerve fibers. No part of the brain has so much in so little space.
Can you please share your screen again?
Yeah. Oh, I thought you're already seeing it because I'm. One second, I'll do it again.
Yeah, please share the screen. We cannot see the part.
Oh, I'm sorry. I didn't realize that.
No problem. It was shared once, but somehow
okay. It's gone again. Okay. Yeah. Yeah. Are you able to see it now?
Yes.
Yeah. So just probably, I'm not sure whether you saw this slide. So this is the agenda that I'll be going through: anatomical perspectives, functional uniqueness, radiological tidbits, surgical significance, and finally a bit on the future perspectives about the callosum. So perhaps we all, feel that the callosum actually means a bridge, very literally speaking. But you're right about it. It is a bridge, and these are some of the famous bridges all over the world. And you may be a little more closer to some of these bridges in whichever part of the world that you may stay. But then the callosum actually, in the true meaning of the word, stands for something which is very tough. And it is actually so if you look at it, because this is a structure which extends almost, connects to every part of the brain directly or indirectly. Perhaps you would ask me, how can you connect it with Professor Roy's talk, the intertentorial approach? I will prove it to you how we can connect the callosum to the intertentorial as the talk goes by, because the callosum is closely related to the phonics, and the phonics goes way down to the tinea fimbriae of the phonics, which is actually lies on the tentorium. So there is no part of the brain perhaps which has no connection with the corpus callosum, and the callosum maybe in a literal sense is a brain bridge, but actually it means a very tough body. And every path in life has a bridge, and the journey is in crossing it. So what we would be exploring today is how to reach the callosum. Crossing is it for access beyond the callosum, and most importantly, from an adverse event or staying clear of adverse event perspective, getting back safe after reaching or crossing the callosum. So this is perhaps the most important of the gist of the corpus callosum. So as a neurosurgeon, for us, sometimes it may be a path on your way to a destination, or it could be your surgical target. For example, if you're doing a callosotomy as an epilepsy surgeon, or a hemispherotomy, wherein the callosotomy is actually your destination. While if you are going into the ventricle, that is the lateral ventricle or the third ventricle, or even perhaps beyond, it is a station en route to your final destination. When you're going for a colloid cyst, or when you're going for an intraventricular tumor, a lateral or third ventricular tumor, or a hypothalamic hamartoma through the interhemispheric approach. And most importantly, sometimes you may actually use it as a key intrinsic brain anatomical landmark, because it tells you where you are. It is a lighthouse in a sea of brain parenchyma. So when you're operating upon a distal anterior cerebral artery aneurysm, when you're operating a diffuse cingulate butterfly glioma, sometimes you see some part of the callosum which tells you where you're located. When you're doing a posterior quadrant, that is a parieto-occipital temporal resection for epilepsy, again, the splenium is an important landmark. When you're doing endoscopic approaches, endoscopic septostomies, the callosum is an important landmark. So this is, a different perspective on the callosum. So if you actually look at it, there are a class of mammals called eutheran mammals. So these are the mammals who don't have a placenta, or the placental mammals, and those who don't have a placenta don't have a callosum as well. So you have birds, you have reptiles, you have amphibians, fish, you have the platypus and the kangaroo, which actually they don't have a placenta and they don't have a callosum as well. Perhaps this is some area where basic science researchers can dwell upon in future. So from the anatomical perspective, this is a very wonderful artist's pencil sketch, where you can see that the callosum actually connects so many structures in the brain. Almost all the both the diencephalon and the cortical surface is almost connected. Every part is connected with the callosum, and these are the major brain commissures. So the corpus callosum occupies rank 1 in this: the anterior commissure, the posterior commissure, the habenular commissure, the fornix, the occasionally seen middle commissure or the massa intermedia. And we know very well that in the era of white matter dissection fibers, this is how we classify the white matter fibers. So commissural fibers are predominantly seen in the callosum, the projection fibers in the internal capsule, and then you have got these intergyral connections like the uncinate fasciculus. So association fibers again have a lot of contemporary relevance in the era of white matter dissection. So we had Dr. Roy speak to us about the IFOF, the inferior fronto-occipital fiber, and all of these, have some connection with the callosum. And this is another perspective of the white matter connection fibers, which again indirectly or directly have their origin in the callosum. So, if you look into the evolution and the history of callosotomy or the understanding about the callosum, it's very, very fascinating. So, initially, it was Dandy who used it from a surgical perspective for pineal tumors. And then there was a whole lot of change in the thinking about it in 1940, when von Wagenen and Herren, in a very classic publication in the archives of neurology and psychiatry, they described the concept of a corpus callosotomy. That is when they really understood that perhaps the disconnecting the corpus callosum would help to limit the spread of seizures from one hemisphere to another. So there were ups and downs. Any new idea, there are people who initially accept it. They are the revolutionaries. Then it takes some time for the idea to sink in. So it came about in 1940, and then there were some experiments both in the primates and the split brain experiments, which were revived by Bogen et al. In 1960s. And then after a short dip, again there was an era of callosotomies in the 1980s and 90s. So the dip was perhaps because there were a lot of new anticonvulsants which came about in that era. And then again there came the era of staged or multiple callosotomies, anterior callosotomy, staged callosotomy, and today we are in the era where several papers have also come on radiosurgical callosotomy. So, split brain studies are very, very fascinating part of the history of callosum. And this is when we actually understood the concept of disconnection syndromes as well. And the man behind it is Robert Sperry, who was actually awarded the Nobel Prize very late in his career in 1981, though the studies were mostly done much, much earlier than that. And the most commonest disconnection syndrome, which we see, alexia without agraphia, is perhaps an outcome of this split brain studies. So callosotomy again was revived by Bogen and Vogel, and these are the three big names of callosotomy standing together and sharing a few thoughts on the callosum. And the embryology of the callosum is also very, very fascinating. So here you could see that in the earlier weeks of gestation, you don't see anything connecting the two hemispheres, but slowly you can see the callosum coming up, and it's in the 12th to 16th week of gestation that you have the callosum developing well. And I'll come to a few radiological pictures of callosal agenesis to understand this concept better. And this is the topography from a coronal perspective. You need to travel some distance to reach there. And there may be morphometric variations in how much distance to travel, depending on the thickness of the vault, depending on the morphology of the cortical structures. So this is again the subdivisions of the corpus callosum. We know the rostrum, and a small structure here at the base of the rostrum is the anterior commissure, which we usually encounter while opening the lamina terminalis during aneurysm surgeries. The genu, the body, which is perhaps the vertically thinnest part of the callosum. The isthmus also is in some patients as thin, and then the thickest and the most prominent part is the splenium of the corpus callosum. So though it's a long structure, you could realize that maybe even through a small incision, this being a deep structure, can be accessed. The entire length of the callosum perhaps can be accessed through a 1 or 1.5 centimeter exposure. So this is a perspective of the forceps minor, which is like a curtain draped on the callosum, and the forceps major. And these are the radiations from the corpus callosum, which have a very typical surgical appearance. And the callosum also is a station en route to the third ventricle. So these are multiple routes to the third ventricle, and through the callosum is one of the many routes. I'll come to that in one of the future slides. And the blood supply of the callosum is quite interesting because you might encounter it while the callosum, while dealing with arteries of these vessels which supply the callosum, the anterior pericallosal and the posterior pericallosal from the PCA. And we have the division of the anterior cerebral artery based on the coronal suture, and its lie on the corpus callosum. And the venous drainage also is very, very interesting to note, but there are no large prominent veins. That's what probably makes it less appealing to surgical bravado, and we don't really tend to go wrong too much as far as coagulating large veins are concerned while we do a callosotomy, at least on the callosum. Maybe the interhemispheric fissure, while we develop it, we need to preserve these large interhemispheric draining veins, but here the posterior callosal vein here drains into the vein of Galen, and the anterior callosal vein here, it actually drains finally into the septal vein. And I'll show you a picture from the Roton Atlas where you could see that there is a good collateralization of the venous drainage on the callosum, which gives the surgeon some leeway for maybe sacrificing small veins on the callosal surface if they come in your way. But the general principle is to keep usually the ACA and the arterial supply of the callosum out of your way when you do a callosotomy. So the other two structures which are almost spoken about in the same breath as the callosum are the cingulate and the fornix. These are also much neglected parts of the brain as far as neurosurgeons go. But the cingulate gyrus sometimes can be, especially for beginners, a common question is how do you differentiate between the cingulate and the corpus callosum in surgical exit exams. So that sometimes is a difficulty, especially when both the hemispheres are, there are a lot of adhesions between the two hemispheres, and the cingulate also has got a lot of significant functions, being a very important organ in decision making and several cognitive functions. And the fornix too, being a very important structure at the base of the callosum, and it has got different orientations as you go along the callosum. So the anterior callosum and the rostrum and the genu have got a slightly different orientation as to the fornix as compared to the body and the splenium of the callosum. And the cingulate cortex again has got a lot of function, and language expression and communication being one of the most important functions. That has got a lot of spatial orientation as well. So these colors are the different spatial orientations of the cingulate cortex, and we really wouldn't be right to speak about the callosum without giving some form of credence to the cingulate cortex and the fornix as well. So this is again the blood supply of the cingulate cortex, very intricate at the same time, good collateralization, which gives us leeway for maybe sacrificing some of its arterial supply if we need to get better access. So the fornix, a very, very fascinating part of the brain. When we see it, actually, separately like this in a picture, it looks a lot more simpler. But when we see it in perspective, along with the callosum, it may not be very easy to really identify it in this manner. So this is the anterior part, and then this is the body of the fornix. So, and these are the crux of the fornix, and this is the hippocampal commissure, so through which both the hippocampi are connected, and this is where we have the tinea fimbriae of the fornix, which actually lies in very, very close relation to the tent. So that is the connection between the first and the third talks today. So this is how the callosum, actually any signal through one hemisphere can be easily transmitted to any part of the other hemisphere through the fornix and the callosum. So the septal area is again a very neglected part, and I just quickly take a moment to spend some time on it, because from the perspective of temporal and temporal plus epilepsy. Temporal plus is epilepsy which appears to come from the temporal lobe, but it actually originates outside the temporal lobe and can fool you, or sometimes it can make a feeling that it is from the temporal lobe and contribute to surgical failures after epilepsy surgery. So the entorhinal cortex, which is again the medial part of the temporal lobe, the rostral gyrus, the gyrus rectus, and the anterior part of the cingulate gyrus. And you have a lot of other, maybe theoretically important, less surgically important gyri like the subcallosal area, the posterior para-olfactory sulcus, the paraterminal, which are all very, very fascinating, morphological structures within the basifrontal and medial temporal lobe, which again have got a very close relation to the callosum. So I'll start off with the callosotomy for epilepsy, though I would always leave a word of caution that the callosum doesn't belong only to the epilepsy surgeons. It is an equal right of all neurosurgeons to understand the callosum, and it's not just for the epilepsy surgeons. So the callosum is a critical pathway, and what we do in a callosotomy is to interrupt this largest commissural fiber. And these are the usual scenarios in which we do a callosotomy, a Lennox-Gastaut syndrome, which is almost similar to an epileptic encephalopathy, West syndrome, wherein we don't have a primary resectable focus. So the seizures actually are from both the hemispheres, and by disconnecting both these hemispheres through a callosotomy, we offer some form of a palliative option. And but then again, there are a lot of questions which still remain unanswered in the current era. How much callosotomy would be ideal? What is the effectiveness for other seizure types other than the atonic seizures? Is this still relevant in the era of vagal nerve stimulation, which is considered to be a big fad and less invasive? And could callosotomy fail? So there is a lot of classifications or subdivisions within the callosum, and one of which is a radiological classification, which is a Witzelsson scheme, wherein you have these subdivisions of the callosum, 5 zones, and actually there is a topographic and a functional organization of these 5 zones. So that is how some of these disconnection syndromes are different in different parts of the callosal disconnection. And this is a DTI picture of the callosal fibers, which shows very fascinating array of fibers. And about 70 to 80% of the cortex is connected by the callosum, and it's usually around 7 centimeters long, and the average thickness is 1 centimeter. So this is the topography of the callosum, which I was just speaking about. So some part actually connects the premotor cortex, some part connects the precentral gyrus on both sides, and it almost corresponds to the topographic or functional organization of the rest of the cortex. So disconnection syndromes again are often spoken about, and often they deter us from going full blow or full blast while doing a callosotomy. So the question which really comes is that, are they really there? So the answer to that is they are there, but they are not so much there as they are theoretically made to sound. So most of these patients who undergo a callosotomy are already cognitively so disabled that a small additional cognitive blow to them really doesn't make a difference, because it might give them the greater gain of seizure control, or palliative seizure control. So that is why, except for the alexia without agraphia in parieto-occipital disconnections and the supplementary motor area SMA syndrome, most of the other disconnection syndromes are not usually permanent deficits, and even the others are not really permanent, and they resolve over a period of time. And this is the morbidity of drop attacks or atonic seizures, and this is the concept of palliation in callosotomies. And the best outcomes are usually seen with drop attacks, the Lennox-Gastaut syndrome, and the seizure semiology of drop attacks has got the best outcome. So variations are, we usually prefer to do complete callosotomies for drop attacks. And this is a DTI for callosal fibers to show where the callosal fibers are actually connected with, not essential as a preoperative investigation, done more for theoretical and academic purposes. And this is posterior quarter intersection, which is done usually for parieto-occipital large gliosis or focal cortical dysplasias, and which has a splenial disconnection. So this is the usual surgical technique for a interhemispheric complete callosotomy. So this is the supine position, the head fixed on a 3-pin Mayfield clamp, and there is a parasagittal incision. This is the usual craniotomy, which is extending across the midline. We develop the interhemispheric fissure very gently. We have to be aware that there could be some morphometric variations, and that the vertical length of the callosum can vary at various locations. And these are some of the distances that we may need to cover through this small incision. So, the longest distance can be even as long as 7 to 8 centimeters in adults. So this is the disconnection of the interhemispheric fissure, and this is the callosal exposure. And this is a small quick video after the callosal exposure, and a part of the callosotomy has been done. So this callosotomy for epilepsy is slightly different from the callosotomy for lateral ventricular exposures, because here we have, this is the body of the callosum which is being disconnected. And after the disconnection, we are actually going deep into to get a interfornicial disconnection. So this disconnection extends right from the anterior commissure to the genu, through the entire the rostrum, the genu, and the body of the corpus callosum right up to the fornix. And we also do a interfornicial disconnection, taking care not to open the ependyma of the lateral ventricles. If the ependyma gets opened inadvertently, there's no harm, because it probably increases the risk of aseptic meningitis or something like that. Here you can see the two the columns of the fornix very nicely seen, and the ependyma very intact. You can see the septal vein through the ependyma. Here is the septum which is being gently dissected open. And if inadvertently the ventricle actually opens up and some CSF seeps out, there's no problem. We just need to ensure that too much of blood doesn't seep in. So this is the interhemispheric callosotomy for the indication of Lennox-Gastaut syndrome, atonic seizures. And this, you can see the ependyma pulsating well. So this is occasionally we use neuronavigation to identify the draining veins, not as a routine practice. And the outcomes are best for atonic seizures, and for generalized tonic-clonic and CPS, not so much. And prognostic factors definitely depend on the duration of seizures, shorter duration, better outcome, type of seizures, atonic seizures, and some EEG patterns, which are more interest to the neurologists. And not just seizure outcomes, we also have some collateral gain in the form of improved quality of life, emotional well-being, and so many other things. So the caregivers are also, significantly satisfied, because patients become significantly independent. And adverse event disconnection syndromes, memory deficits, to some extent, new type of seizures occasionally may develop if there are reconnections, transient neurological deficits, and very rarely permanent neurological deficits. Sinus injuries, pericallosal vessel injuries are extremely rare in experienced hands, and late complications could be aseptic meningitis and hydrocephalus due to that. So these are the disconnection syndromes. The SMA syndrome sometimes can be very worrying due to a premotor retraction, but it gets better over a period of time. And alexia without agraphia is one of the disconnection syndromes which actually stays for some time, but again resolves to a great extent. And the prognostic factors we just discussed, drop attacks have the best results. And total callosotomy, the extent of section, the higher extent, the better the outcomes. So there could be sometimes late failures because of commissural reconnections, and perhaps scope for reoperations as well. We have done a couple of them many years, more than 5 years after the initial callosotomy. This is endoscopic total callosotomy, which has been published as a cadaveric study by Dr. 𝒂𝒏𝒔, one of our earlier alumni from our department. And this actually proves the concept that through a small exposure on the surface, you could access the entire callosum. These are cadaveric pictures from that paper by Dr. 𝒂𝒏𝒔. And image guidance, again, can be of advantage in situations to avoid ependymal breach, to plan the extent of callosotomy, especially in redos. Radiosurgical callosotomy is an evolving technique. And we had published our experience a few years ago when we had favorable outcome in 82% of patients in the complete callosotomy group, while only 33 in the partial callosotomy group. And these are a few schematic pictures of the lateral ventricle after callosotomy. And this is the typical interhemispheric approach before you start a callosotomy, where you see the ACAs, which you could perhaps retract to one side to avoid any form of injury. And there could be, a deficient FOX in many places. So opposite hemisphere, and preserving it also is a matter of great concern sometimes. And this is after callosotomy, both the ventricles, frontal horns exposed in a callosal glioma. This is the bed of a callosal glioma resection. These key intrinsic anatomical landmarks help us to understand it better. And this is a posterior quadrant disconnection, which is done in a prone position. This is after the posterior quadrant resection. You can see this white structure which peeks at you, which is the splenium of the corpus callosum at the falcotentorial edge. And just below this is the quadrigeminal cistern, a very key anatomical landmark in a posterior quadrant resection. And just a quick word about callosal agenesis. So this is how a typical scan of callosal agenesis looks like. And callosal agenesis may be associated with Dandy-Walker-Chiari Apert syndrome. And this is how a typical agenesis looks like. And the classical sign that is described is the racing car sign, where you could see the ventricles very prominent here and no callosum here in between. So Aicardi syndrome again is a very classical EEG picture, which your neurology colleagues are always fascinated to see. So you could see that, because of there is this total disarray of electrical activity between the two sides, because there is no real connection. So both of these are completely independent of each other, because there is no connection between the two hemispheres. And these patients usually present with infantile spasms and callosal agenesis. So this is what is known as a Probst bundle, which is a teardrop-like appearance of longitudinal callosal fascicles. And these are a few radiological pictures of DTI pictures of callosal fibers. A corpus callosal lipoma is a classical picture. A splenial lipoma, glioma again is a very classical picture. This is a lymphoma which involves the corpus callosum. These are the typical appearance of multiple sclerosis. This is known as a typical lion's paw appearance. And this is the callosal degeneration, which is seen in chronic alcoholism, Markey-Bignami disease. More, again, a fascinating illness for neurologists. So callosal infarcts may occasionally be seen as part of vasospasm in aneurysmal bleeds. And callosal AVMs, again, are not very uncommon. So almost no disease spares the corpus callosum. And this is the callosal bleed, which is a typical feature of a diffuse axonal injury. And this we know is DACA aneurysm. So this, again, coming to the surgical significance, is that this we spoke about callosotomy, which is the surgical target of the in corpus callosum. But it could also have the this callosum could be a station en route to a surgical destination. And these are the approaches to the corpus callosum. Interhemispheric, you could even reach there transcortically. First you reach the lesion and then you reach the callosum, or transcortical intraventricular. So this is very fascinating, which we do in a hemispherotomy, both the vertical and the horizontal hemispherotomy. Through the cortex we reach the callosum. I'll quickly show you a video of intraventricular tumor, a pilocytic astrocytoma. In the interest of time, I'll go a little fast with this. This is, I hope you. So this is so I'll just fast forward this video. So this is the lesion, which is a very large intraventricular lesion, and we approached it transcallosal, and this is the large lesion. So we had no clue what it was. We thought it would be a typical intraventricular lesion like a neurocytoma or any a glioma maybe. So as this patient was in the supine position, and we went through the interhemispheric corridor. Yeah, so this is the corticectomy, which was gently being done through the interhemispheric corridor. And as we zoomed in, we could, as soon as we entered the hemisphere, we could see the tumor, not very moderately vascular, pale yellowish, and in a piecemeal manner, taking care of all the intraventricular landmarks, because in these tumors, there are always blind areas, and there's always a concern on whether you need to increase your callosotomy. But often, as the tumor goes, you go ahead with your tumor decompression, you are able to reach the limits, and the key anatomical landmarks help you to this is almost the last part of the tumor. You may need to sometimes, since this had already gone across the septum, we didn't need to really do a septostomy or a septal incision, which was already there done by the tumor. And this is the last part of the tumor, and then we left an intraventricular drain. And the post-op scan actually showed a complete excision of the lesion. We also have a delayed MRI which showed a complete excision. The biopsy was a pilocytic astrocytoma, which was which was a diagnostic surprise. So vertical callosotomy is a situation wherein we actually through the cortex reach the callosum. So this is a vertical callosotomy done for a porencephalonic cyst and a corticectomy done on the surface of the right frontal lobe. And after we enter the frontal horn, we need to align our microscope to here. You can see the callosum. We see the groove of the corpus callosum through the ventricle and gently develop it. Here it is. This is a septostomy which is done to prevent any delayed postoperative hydrocephalus. And this is the groove of the corpus callosum seen through the ventricle. And here is a intraventricular transcortical callosotomy which is being done as part of a vertical hemispherotomy. So in fact, this extends right up vertically till we see the ACAs in the callosal system. And as it goes further, we can see the ACAs, and we also trace it anteroposteriorly till we see the ACA right from its origin in the from the internal carotid artery. And posteriorly, we extend it right up to the splenium. In the interest of time, I'll just quickly go through this. You can see that the ACAs has already come into view here. You can see it turning around at the genu of the corpus callosum and going further deeper in. So this is one of the important key steps in a vertical hemispherotomy, a transventricular callosotomy. And the next is the same in a horizontal or a suprasylvian hemispherotomy, which is the Willems modification. Here again, we do a corticectomy on the suprasylvian aspect, creating a suprasylvian window. We've entered the this is a left-sided callosotomy, and through the cortex again, and through the ventricle, we're doing a transventricular callosotomy. The landmarks still remain the same, though the distances and the orientation may vary slightly. This is the transventricular callosotomy, and you can see the cingulate gyrus of the opposite side when you finish your callosotomy. And we have entered the callosal cistern of the same side. So you can see both the anterior cerebral arteries here. So this is the orientation after we complete the disconnection from the left side and the vertical approach on the right side. A transventricular callosotomy, this is it, and this is in the vertical approach. And the final disconnection bed, that is the thalamo-basal ganglionic system, disconnected from the cortex, looks like this. And though the orientation in both is slightly different, the distances are slightly different. The splenium of the corpus callosum in the vertical approach is slightly more distant, while it is less distant in the in a horizontal approach. So this is something, these are just morphometric variations which we need to keep in mind. And the callosum is also an important structure in approaches to the third ventricle. I'll quickly show you a picture. And we can again further modify this into the transforaminal, the transfornicial, transchoroidal, and interfornicial approach. Though we may sometimes not be very conscious about it, especially in large tumors, when we already see the tumor before we actually look into or plan these approaches. So this is a third ventricular tumor, wherein you can actually see that the tumor lies here in the third ventricle. This is the choroid plexus of the left lateral ventricle, and here we are in the right lateral ventricle. We are exactly in the center through an interhemispheric and interfornicial approach. So this is how it looks, and this was a pilocytic astrocytoma. Future perspectives is that maybe image guidance, though it was used for first time, is still evolving. Gamma knife callosotomy, endoscopic callosotomy, LITT, laser for callosotomies, radio frequency ablation. Again, these are evolving new sectioning techniques that may sometimes challenge surgical frontiers tomorrow. And I would end with a very important take-home message that though the callosum doesn't enchant us as much as those vascular bloody structures, but then it definitely has its own surgical significance. Is it a surgical target or a station en route to a target? Whatever it is, it continues to fascinate us. And there is a difference in callosotomy for tumors, for epilepsy. We have to identify key intrinsic brain landmarks with respect to the callosum and stay safe. Disconnection syndromes, though often spoken about, are not really very permanent, or we need not be too much wary about them, as they are often transient and improve over a period of time. And this is the center where I work, the Madhavan Nair Comprehensive Epilepsy Care Center at Sri Chitra. And this is our team of epileptologists and the neurosurgery team. And this is our neurosurgery team who are mainly involved in calosotomy for tumors. And thank you very much for your very, very patient hearing, and thank you for this wonderful opportunity.
Yeah, George, thank you for a very comprehensive overview, illustrated with good examples and good quality, both videos, pictures, and content. So thank you again. I will open it up to brief comments or discussion. Maybe we can, this time, instead of having you as the last word, we can have you as the first word, Professor Karagiozov. Any comment would you like to make?
Really comprehensive presentation. We had a very, very interesting comments on epilepsy. I will be very brief because also of the time concern. Just a question about the plasticity that we are going to rely after calosotomy, particularly in children and in adults. The majority of calosotomies are in children in general. So how is your opinion regarding the ability to compensate as much as possible? And particularly, as we know that corpus callosum is a structure that keeps on myelinating maybe until the age of 30 sometimes, and so on. So how do you see this kind of compensation of functions in the different contexts and scenarios?
Thank you, Professor Constantine, for that wonderful question. I think it's a real problem because the functional plasticity and functional reorganization, we are still not understood it really well. And we in epilepsy surgery exploit plasticity by doing early surgeries for children. And that is something which we heavily rely upon to get good outcomes, both in hemispherotomies and in calosotomies. But then the good thing about plasticity is that once you intervene early, and they say that the most plasticity is within the age group of 2 to 6. So any highly epileptogenic lesion diagnosed within the age group of 2 to 6, we really don't need to wait for the International League Against Epilepsy, ILAE's technical definition of drug refractoriness or drug-resistant epilepsy, which says 2 drugs with adequate combinations for 2 years. If you know you're dealing with surgically remediable epilepsy, and you know that this is eventually going to be drug-resistant or anti-seizure medication refractory, I think we need to offer surgery early, and that is true for calosotomy as well. So most of these subsets of patients already have epileptic encephalopathy. So epileptic encephalopathy means that you have multiple areas in the brain which are independently epileptogenic. So you might have started off with a small focus. In fact, a couple of indications which I have really not mentioned because they're still evolving are patients with multiple tubers and tuberous sclerosis. So we know that the cornerstone for epilepsy surgery is to have a focal resectable lesion of focus. And after resection, you should be able to have a functionally intact patient. So, when a situation like this, wherein there is primary generalized epilepsy arises with drop attacks, you don't have a resectable focus. But at the same time, you allow the patient to face the brunt of recurrent seizures. Then what happens is that multiple areas in the brain, here you might have just 2 foci on 2 areas of the brain, 2 tubers which are seizurogenic. But then when a network develops, multiple areas of the brain could be independently epileptogenic. So definitely functional reorganization or brain plasticity is something we need to capitalize on very, very heavily. And the message especially has to go out far and wide to the first contact doctors. That is, in this case, with children, are usually pediatricians who have extremely low exposure to epilepsy surgery. So their concepts are usually to try new combinations of anticonvulsants. So the message needs to go far and wide that we have even palliative surgery options like calostomy definitely have good quality of life outcomes, and we have a few patients who have even had curative benefits with calostomy. So functional plasticity is something as epilepsy surgeons and as neurosurgeons we need to capitalize on, and in this context with respect to calostomy. But there is a negative side to plasticity as well, as Professor Constantine said, that one of few of the failures of calostomy again are because of more of structural plasticity rather than functional plasticity. So you have remyelination, you have re-establishment of these so-called structural commissural fibers which you disconnected during a calostomy. So there is a school of thought which says that just a disconnection is not enough. You might even need to resect some part of the callosum to get better outcomes. And how to ideally assess these patients? Do you need a DTI, especially in late failures? We've had a couple of late failures, but they were all probably because of the initial calostomy itself being a staged calostomy. So we've not had too many failures in complete initially planned calostomies, but then only time would tell. So as maybe we go into longer outcomes beyond 10 years, maybe functional reorganizations and failed calostomies might be a problem which we need to find ways to address.
George, before you carry on, let me project there with one question from the audience. Do you carry out endoscopic transcallosal approach for lateral ventricle lesions? And what types of cases would you do endoscopically? If you could answer briefly, please.
So endoscopic approaches for lateral ventricular tumors, we don't do it commonly in our institute unless they are extremely small lesions which you think are going to be very avascular. So we usually prefer the open approach. But I have seen a lot of proponents for endoscopic approaches for lateral ventricular tumors. So I'm not an expert to speak on that. But definitely, as the callosum is a very important landmark, and also the associated structures like the septum and the fornix, a very thorough surgical anatomical understanding of these structures is very essential for success of endoscopy as well. Because finally, when you are dealing with a large intraventricular tumor, you are lost in a sea of brain parenchyma or a sea of tumor. So how do you know you have reached beyond? So you probably, even navigation has its own fallacies because of brain shifts in intraventricular tumor. So these key intraventricular landmarks, the septum, the intraventricular view of the callosum, and the the choroid plexus, the choroidal fissure, all these landmarks which comes from your understanding of the callosal anatomy are very, very important in a complete resection of intraventricular tumors, be it endoscopic or be it via an open microsurgical approach.
Okay, we're near the end. I would like to ask Professor Ohtani for a commentary, and then Professor Kato for some closing remarks.
So may I one question?
Please.
Yes. So it's very good but complicated presentation. So I'm not a non-specialist for the calostomy, but I can get so many knowledge about the corpus callosum through your presentation. Thank you so much. So my question is, how do you decide the surgical indication of the general calostomy for the general seizures? Such as the resistance for anti-seizure drugs, right?
Well, thank you, Dr. Ohtani, for the question. So before I start, let me add a disclaimer saying that this is not my patented area just because I am an epilepsy surgeon. I don't have additional access to the callosum. Callosum is as much as a general neurosurgeon as it is for an epilepsy surgeon. And to answer your question about the pre-surgical workup, so in epilepsy surgery, calostomy is decided very, very carefully. And it is a pure calostomy, which is done through the interhemispheric approach, is done usually for primary generalized epilepsy for patients who do not have a resectable focus. And you know that the seizures originate from both the hemispheres, and you want to interrupt the spread of seizures from one hemisphere to another. The best outcomes are seen with a particular semiology, that is the drop attacks or atonic seizures. So there are particular syndromes like the Lennox-Gastaut syndrome, wherein they have the best results. So patient selection is very, very important. And then callosotomy is also done as an adjunct in other procedures, like for example, hemispherotomy, a functional hemispherotomy. A functional hemispherotomy is actually a procedure done for hemispheric epilepsy syndrome. So where the entire focus of epilepsy is the entire hemisphere. So that could be probably because of a porencephalic cyst or a hemimegalencephaly or a large 𝒂𝒏𝒔 or a large focal cortical dysplasia. In such situations, along with the disconnection of the cortex from the thalamo-basal ganglionic system, you want to also interrupt the entire hemisphere from its seizures spreading to the opposite side. So as an adjunct with the other disconnections of a hemispherotomy, we also do a callosotomy as part of hemispherotomy, but these are not standalone callosotomies, and they are done, as I showed in the video, transcortical, transventricle.
Yeah. What do you use intraoperative monitoring during the callosotomy to avoid the complication? Right. Intraoperative monitoring do you use?
Right. So when, as compared in epilepsy surgery, intraoperative monitoring has got two perspectives. One is intraoperative monitoring or intraoperative recording of interictal activity in the form of by using a electrocardiogram. That is an intraoperative electrocardiogram. And the second is for functional mapping. So in a typical callosotomy that we do, we are not likely to in any way disrupt any functional cortex. So we don't do any form of functional mapping. And as part of a routine protocol, we really don't do even intraoperative electrocardiography. So intraoperative electrocardiography is usually done for focal resections when you want to tailor the resection based on post-operative residual spikes or residual ictal activity. So in such situations, when you want to tailor the resection or modify a resection based on intraoperative ictal activity, that is when we use intraoperative electrocardiography. And in a situation where we have a fixed anatomical disconnection which is planned, as in a callosotomy, this wouldn't help us any further to modify our resection. So we really don't use it. But then there are a few papers and few authors who have been using it mainly for prognostication purposes. So what they could actually do is they could record electrocardiography from one hemisphere of the brain before the callosotomy and also from the other hemisphere before callosotomy, and then simultaneous recordings after callosotomy. So as you know that EEG recorded directly from the cortical surface is the most pure virgin form of EEG or electrical activity. So it does away with scalp artifacts. So for research purposes and prognostication purposes, a lot of authors have been using it, centers have been using it, but we don't do it routinely.
Yeah, thank you. Thank you so much.
Most welcome.
Thank you again, George, for an excellent presentation. We've had a great day. We've had a presentation on betrothal approaches by Professor Daniel from Switzerland. Had a talk on STA-MCA bypass from Dr. Biswas from Bangladesh. And we had an anatomically relevant presentation by Dr. Villanilam on the corpus callosum. So for the closing remarks, it will be a pleasure to ask Professor Kato to close the session.
Okay, thank you very much, Andres. So Andres is a very super excellent, the chair. Thank you very much. Over the 2 hours, I think. So this is a not good webinar for YNS, but for all of us, I think. We learned a lot, especially the anatomical base, and also so many variety of the topics, I think. So I think we should continue with this wonderful webinar in the future. Thank you so much. ありがとうございました。
ありがとうございます。
Thank you, everyone.
Thank you. Thanks so much.
Andreas, thank you.
Yes, bye.
Thank you for the time. Thank you.
Thank you.
Thank you to everyone, in particular our discussants, Professor Otani, Professor Karagiozov, the young generation who organized it, with Ben and Raj, and again to our panelists. Great to see Professor Pizat, Professor Suresh, and everyone else here. So thank you so much.
Bye bye. See you all. Bye.
Okay, Dr. Raja and all.